In a prior video, my phone died, so I had to charge it up and then continue. But now we're on the extremities, so I would put new gloves on. We're in the extremities. So I would check the arms for skin, hair, turgor, and temperature. So make sure the skin is warm, and check to see if the skin is warm or cold. I would say the skin is uniform with color, good skin turgor, dry, intact, and the hair is evenly distributed. Then I would go down to assess the absence or presence of lesions. So skin is absence of lesions, absence of edema, warm to touch, and then I would go continue absence. I would note any scars on the arms or the extremities, any abrasions. So no lesions, ulcers, scars, or abrasions. Then I would move down and inspect the palms, supination, pronation, inspect the palms and the fingernails. So absence of clubbing. I would do a cap refill less than 3 seconds. Then I would have the patient close their eyes and ask which fingers being touched. Same thing with the other arm, and I would try to draw a number in their palm and see if they can tell me which number that's in their palm. Then I will proceed to I'll take something like a pen and I'll put it in their hand and say, "Can you tell me what this is?" Then I'll take something else like a water bottle and put it in their hand and say, "Can you tell me what this is?" Just so they can recognize what things are of that nature. And then I would probably just continue to go down, cap refill. Oh, then I would do finger strength. So I would have them do finger strength. So basically I would have them grip my finger. So I'll put my 2 hands in between, have them grip my fingers bilaterally to test their finger strength. Then I would say strength in both arms, strength in both hands is even. Then I would check them, palpate their auxiliary nodes. So the lateral, the superficial, central auxiliary, the posterior, and then I would do the anterior. Then I would inspect the epitrochlear node and no swollen nodes, anything like that. Then I would go down to their lower extremities. I would inspect their legs, absence of edema, lesions, or anything like that. So move down. Then I would inspect their legs. Absence of edema, skin is uniform color, good skin turgor, dry, evenly distributed. I would check for lesions, ulcers, absence of lesions, ulcers, abrasions, or anything like that. Check the cap refill on both toes. I want to check in both. So less than 3 seconds. I would inspect hands and feet, good pedicure, no clubbing. I would have the patient close their eyes and identify which toe I'm touching. I would have them, I would put my hand on top of their toes and I would have them press up. So I would have them move their hands up with resistance, and I would put my hand down and have them press down like they're pressing down on the gas pedal. So yeah, then I would palpate and inspect the ankles, no edema noted, or anything like that. And then of course I would ask the patient to turn their side. I would inspect their back, make sure their back is fine, everything, no edema on the back. And I would inspect their arms for lesions. I would inspect their anus. If I would tell them to turn over, and inspect their anus for hemorrhoids, lesions, or fissure discharge, any discharge. And I would lay the patient back on their back. While I'm here, I could do range of motion in the legs. So basically, I would do adduction, I would do abduction, I would do circumduction in both legs, adduction, abduction in both arms and legs, circumduction. Basically some range of motion exercises with the arms and legs, so I don't have to have the patient move around too much. And I would check their dorsal pedis pulse and their tibial pulse while I'm down there. Then I would sit the patient up. I would tell the patient stand up. Before I made the patient stand up, I would verify that the bed is locked. So make sure the bed is locked and the patient can't go anywhere. So I would stand them up and I would have the patient put on socks. I would put the bed in the lowest position, which I would move the bed down to the lowest position. Then I would check the pulse for 1 minute. After I check their pulse, I would have the patient stand up. When I have the patient stand up, I would make sure that the patient is not dizzy. So I ask the patient, "Oh, do you feel any dizziness or anything like that?" before we move forward. Because, you want to check to make sure they're not dizzy so they don't fall or anything. Because, some people stand up, they haven't stood up in weeks or anything like that. So they stand up and they're dizzy. So then I would check the pulse again once they stand up and dizziness. I would check their knee jerk. So I would hit their knee with the tool, check for knee jerk, of course. Then I would listen to their lung sounds again. So I would assess for tactile firmness with my hand. So I basically go on the back, 99, 99, 99. Check for tactile firmness on the back, for crepitus and things like that, and make sure I can hear. I would check for bronchophony, 99 with the stethoscope. I would check for egophony, the E sound with the stethoscope. I would inspect the posterior chest, standing up, AP, symmetry, 1:2 ratio, symmetric. I would assess the biceps, triceps, and brachial reflexes. Then I would do range of motion of the hands, wrist, elbow. I already did the legs. I would do the hip. I would do the circumduction of the neck. So I'll basically check all of my range of motions at that point, make sure everything's fine. So then I would check the cervical spine. Excuse me. I would check for lordosis, kyphosis, kyphosis and scoliosis. So that's the curvature of the spine. I would check to make sure. I would have the patient stand in front of me and then bend forward. We'll turn around and stand in front of me and bend forward and check the curvature of the spine. What else would I do? I would assess the person's gait. So I would have them turn around and walk 10 steps forward and walk 10 steps back. That's the turn and go. I would assess their gait. I would palpate their joints for heat, tenderness, swelling, masses, deformities, crepitus, anything like that. I would ask their coordination in their gait skills, any movement skills, any problem. I would do the shin to toe or the knee to toe test. So basically, where they put their they take their left foot and then they go down their leg with their foot, and then they take their right foot and they go down their leg with their foot. I don't know the exact name for that, but I think it's ankle to skin to I think it's foot to toe. I can't remember the exact name of that test, but I do know you have to do it. I would assess their posture, gait, their ability to stand. Then I would have the patient sit back down. Then that would basically conclude my test. Make sure I did everything. Self-correct, I would have them do the Romberg test. The Romberg test is what I was looking for. What else? That's pretty much it. That's everything I could think of. So I asked the patient if they had any concerns. They say no. Then I would ask the patient if there's anything else they needed. Then I would, before I leave the room, then I would lower the head of the bed. I would put the call bell within reach. I would wash my hands. I would open the curtains. And that's pretty much it. And that concludes my physical assessment. Thank you.